Hello, everyone, and welcome to this webinar, which is hosted by the European Testing Week. My name is Cecilie Bumkammer, and I'm the coordinator of the Testing Week and based at CHIP in Copenhagen. The objective of our two annual European Testing Weeks is to increase testing efforts and to promote awareness of the benefits of early testing for both HIV and hepatitis. And in line with that goal, we want to highlight some of the approaches and innovations that can increase availability, accessibility, and uptake of testing. In connection with the upcoming European Testing Week, which takes place from the 22nd to the 29th of November, we are hosting a series of webinars to highlight the challenges and opportunities for achieving these objectives. And this webinar is the first in the series of those, which focuses on self-testing for hepatitis C. We have global targets that have been set to eliminate HCV as a public health threat by 2030, but the number of people who are infected and undiagnosed is still very, very high. And there is clearly a need to find new approaches to reaching and testing people. During the COVID-19 pandemic, we've seen testing services being severely hampered because direct contact with service providers have been hampered by restrictions, and self-testing has provided an opportunity to ensure continuation of essential services and overcome barriers to access. But of course, as we know, that's only the first step in the treatment and care cascade. We also need to ensure that those who are tested and diagnosed are also linked to treatment and prevention services. We have a program for you with 4 speakers who will talk about the current recommendations for hepatitis C self-testing, the current status and availability of hepatitis C self-testing, and also some practical challenges related to the implementation of self-testing programs. And on a practical note, we'll have a Q&A session at the end of the webinar. So if you do have questions, please save them for later. And you can ask the questions in one of 2 ways. Either you can raise your hand here in Zoom, and we'll let you speak that way if you turn on your camera, or alternatively you can write in the chat and we'll make sure to read out your questions. Just to make you aware, as we already wrote in the chat, that the webinar will be recorded, so if you do not want your picture, please turn off your camera. We have these polls, as you can see on the screen already. We'll have 3 quick polls, and we would really appreciate if you just take a minute to answer our quick questions, because we get an idea of who's attending and what you think about the webinar and how we might improve in future. So I will stop sharing and I'll introduce our first speaker, Niklas Luhmann, who's a medical doctor. He completed his master's in public health at University of Berlin in 2006. He's been working since on prevention, testing, and care of infectious disease with a focus on HIV and viral hepatitis, and specific expertise regarding access to healthcare of marginalized populations. In July 2019, he joined the Department of HIV, Hepatitis, and STIs at the WHO in Geneva, and is the focal point for hepatitis testing, prevention, and most affected populations. Please go ahead, Niklas.
Thank you. Can you hear me now? Yes. I guess so. I will put my camera on as well. 1 second. Hi, everyone. Thank you very much for having me give the first talk on this important webinar. Can you see my slides now? It was a bit difficult in the preparation. Okay. So as you just heard, I will give kind of the background talk before moving to other talks about the new recommendation of WHO and the evidence that was behind that for building a recommendation on self-testing that exists now since the early summer this year. So many of you will know this slide from the Global Health Sector Strategy 2016-2021. It really highlights kind of the core messages for the road to elimination, with the 2 major impact targets that you see on the graph that were voted by the member states in the framework of this Global Health Sector Strategy. And that was a reduction of 90% of hepatitis B and C new infections, so the incidence reduction between 2015 and 2030, and a 65% reduction in mortality between these same dates, with interim targets that you can see on the slide for 2020. And so that's an important background to understand why we're looking for new and innovative tools to achieve elimination. This slide is as well from the new progress report that was launched as well in the summer this year, or published in the summer this year. And this shows the percentage of hepatitis C infected persons that were diagnosed or estimated to be diagnosed in 2019 in green, and then in yellow the percentage of hepatitis C infected persons that were treated by 2019. So on the left, you can see that only 21% are estimated globally to have been tested and 13% to be treated. So we're talking a lot about testing today. So the testing gap is big. The program target was to test 90% of those who live with chronic hepatitis C, and we're at 21%. You can see as well as we're in a European testing week. Please, a little bit to the right, you can see the estimates for the European region, which are 24% for the testing and quite a high drop-off estimated for the treating uptake. And we'll hear maybe a little bit more around that from Anton later, but just to say overall a similar quite big testing gap to achieve 90% of people knowing their hepatitis C status. This is the standing hepatitis C testing recommendations before we developed this new additional approach of hepatitis C self-testing. So I'll walk you through the slide a little bit. The first part of the slide is the who to test. So it really, the recommendations is a summary of the recommendations from 2016, 2017. So you can see on the who to test that we recommended focus testing for those most affected, such as key populations, and as well as those with clinical suspicion, for example, and others such as family members. And then in some countries, it is recommended to do general population testing, especially when the overall prevalence and burden is intermediate or high. And then there's many countries who see a pronounced hepatitis C prevalence in the older age groups for which birth cohort testing might be relevant. And how to test, we recommended to test with a serological assay, and then with a confirmation through RNA nucleic acid testing, or as an alternate, a core antigen test could be used as well to confirm for viremic infection, as in chronic infection. So this new self-testing recommendation is in addition to those testing recommendation, and is additional approach to the serological testing, because we're talking here about self-testing for the presence of hepatitis C antibodies. And you can see the new recommendation here, where we say that it should be offered as an additional approach to hepatitis C testing services, which is strong recommendation and moderate certainty of evidence. We added a couple of remarks that you can see on the slide, and that I will not read out today to you, but you can see them in the guidance. What was the evidence behind it? That might look a little bit difficult as a slide, but basically just wanted to show you that a WHO recommendation is always made up of several different elements. One of the core elements is to analyze the benefits and harms. It's really the core piece that informs if a recommendation can be made. But values and preferences and feasibility and resource use are almost equally important for the guideline development groups to see if a recommendation can be made and how strong it should be. So the evidence pieces that we brought in here, we made a systematic review on hepatitis C self-testing and its effectiveness. We have found very few studies to be included there. And so we built it, as you can see in green, the existing systematic reviews from HIV in there as a supporting indirect evidence. We used to find studies mainly in orange that were community-led on values and preferences and all the fantastic feasibility work that has been done by FIND, and a FIND Commission study on cost and cost effectiveness in yellow to complete the different pieces of this puzzle. And that was all brought to the group. To show some of the outcomes from those reviews is, as you know, and it was really an important piece to use HIV self-testing as an indirect evidence. And we updated the systematic review. And as you might know, HIV self-testing has shown over the last years clearly to increase uptake of HIV testing. It has shown that often the proportion of people diagnosed is greater than in facility-based testing, and that linkage to care is comparable to more classical approaches, and very little documentation of misuse. The major take-home messages from the feasibility and cost-effectiveness modeling, as I said, that was largely led by FIND and strongly WHO supported, was that many people were willing and able to perform HCV self-tests, that it's acceptable and feasible in many different age groups and populations, and that there's a potential to increase equity. The modeling on cost and cost effectiveness showed that it is possibly more costly per diagnosis than facility-based testing, given the test costs, but that more cases would be diagnosed, and so it can be useful to address parts of the testing gap that I showed in the beginning. So we built the guidelines around this evidence and outcomes, and made the recommendation that you've seen, and further addressed implementation considerations in those guidelines. Here, I think some couple of interesting bullet points on the left that you can see. It's just to highlight that really, if you consider on a country level to introduce hepatitis C self-testing, you need to create an enabling policy environment really to allow for those self-care approaches in national guidance. You need to make sure quality assured products are available, that there is a reasonable choice of delivery models and how it is as well additional to other testing approaches. Linkage pathway has to be as well identified, and then a monitoring system developed. As always, it's very important, and that is one of the core remarks actually in the recommendation, that community engagement is central to building the policies. And so in the guidelines, you can see more narrative and around the different service delivery models that can be used and adapted with some examples. And as well, here you can see that it's important to develop adapted support tools, and that they can range from very different tools, including in-person demonstration to more online or telephone-based tools. More detail is as well in the guidance. Just as my last slide, I just wanted to show you with quickly, I'm not sure if Sonja will comment on that as well. The product pipeline, there's no product with a stringent regulatory approval yet. We know that promising prototypes exist for oral and blood-based versions, and the technical specification series has been published earlier this year. So manufacturers can submit for WHO pre-qualification, but have not submitted final dossiers yet, I think, as I was at least informed 3 or 4 weeks ago. But we expect possibly some news from the submissions for the ERPD from the Global Fund that was open to self-testing products, and where there might have been some submissions. There's several pilot projects ongoing from further looking into the real world implementation considerations and effectiveness through different types of projects, including those from FIND, potentially from STAR implementation partners that have focused mainly on HIV self-testing so far, but might be getting further Unitate support in this area. And for example, another work that WHO and the CDC and FIND did together in the general population in Georgia. And those are exciting pilot projects that will further inform service delivery, implementation tools, and population considerations, and many more. So here you can have the links to videos and recommendations, the guidelines, and the web story as on the slide. And here are my acknowledgements to all the colleagues in WHO and the key partners in this work. Thanks.
Thank you very much, Niklas. Our next speaker is Anne-Isabel van Lingen. She manages the combination prevention program and the policy advocacy work of the European AIDS Treatment Group, which is a patient-led NGO that advocates for the rights and interests of people living with or affected by HIV and AIDS and related co-infections within the WHO European region. Prior to joining EATG, she worked in projects to advance the rule of law, criminal and international justice, and anti-discrimination. Please go ahead, Anis.
Okay, so thank you very much for the invitation. So this what I will present follows up on the findings from our members about the interest in the use of self-testing for HIV and hepatitis, and also following up on the recommendation of the WHO. So I want to introduce my colleague Sarah North, because she was involved in this survey, and she couldn't present, unfortunately, so because she's on traveling today. So this is why I'm presenting. I just wanted to present the diagnostic initiative for community level service delivery. Our purpose is to enhance access to quality and affordable diagnostic at community level. And to do this, we are undertaking cross-country community research, community exchange, and dialogue with stakeholders. So what I will present here is the first part of the community research to understand community understanding on HIV, HCV, self-testing, pricing, availability, as well as practical challenges and solutions. So this is the survey I will present. Currently, there are qualitative research ongoing via key informant interviews, which will be presented at a later stage, because as I mentioned, the interviews are just going on as we speak. So the survey was a 15-question online survey, which was reviewed by EATG members. It was available in English and Russian, and the data collection period was July to September 2021. We had 70 respondents from 37 countries in Russian-speaking countries, and well, we had 48 English-speaking respondents and 23 Russian-speaking respondents. All of them, except for 2, were affiliated with local community organization. And the responses are self-reported, which might explain some of the discrepancies. So as you will see, there is conflicting information in the responses. So this table shows what respondents reported regarding the availability of HIV and HCV self-test kits. So the asterisk on the right-hand side indicates where there was in-country conflicting information. There's one asterisk missing for the Russian Federation. But as you can see, the full availability of HIV and HCV self-test kits is only for very few countries. So there's still quite a way to go. And in some countries, there is no availability of HIV and HCV self-test kit reported. So again, quite a way to go. This table shows we asked about the funding for self-testing programs or availability. And as you will see, in some countries, there's a complete dependence on international and private funding. Very few countries actually have a good mix of funding with local or state-funded projects. So I think more advocacy need to occur at local, but also European level to get governments to support testing program by also community services. So this is the, in these countries, you will see reports on the availability, but also the cost of tests. So in blue is 1 to 5 euros, in turquoise is 6 to 20 euros, and in red is above 20 euros. When you see 2 euro signs, it's because it means that it's for both HIV and hepatitis test. So for instance, when you will see the Russian Federation, this is where we had contradicting information. On the one hand, of no regulation or self-test being available, and on the other hand, HCV and HIV self-test being available for purchase, even with a price. So we need, we are currently looking into this information via the key informant interviews. But as you will see from this slide, there are huge variation in the pricing of HIV and HCV self-test. So the reported restrictions reported by community providers were no approved self-testing that there was no approved HCV self-testing. In some cases, there was no reference to self-testing in national programs. So the fact that it's not a reference in national program means that no government or local state funding is allocated for it. And there's also this requirement for all self-testing to be conducted by a healthcare professional, which means that it's not available at community level. In some cases, it was reported that self-testing is only available for key populations, so it's not widely available. There are also age requirements to access self-testing, and there are limits to the distribution to every 3 months. There's also the impact of local political context, and in one cases, a respondent reported an expired license for certified self-test for professional use. And in some cases, kits can only be sold in pharmacies. This is a slide that shows whether there were reported change as a result of the COVID situation. In 31 countries, 31 respondents in 20 countries reported changes. So these are I don't need to reply. Only one respondent said that it got actually worse. And for instance, Malta, there were some Brexit-related supply issues reported. Several started new self-testing project. And so in general, one can say that there was a reported increase in self-testing programs in country level, in more places and more test kit options available compared to prior to the pandemic. And these are the reports from at 3 level: community level, administrative, and commercial related factors. In general, and also it can be interpreted from the discrepancies in the responses that there is confusion about how self-testing is defined. So which might explain why some responded that it's available, or some did reply that it's not available. There's also a lack of awareness, and which might also reflect when there is funding available for self-testing programs or not. So in general, more work could be done around the awareness and literacy of HIV and HCV self-test. There are administrative factors, which are the lack of regulation, the lack of CE marking, and overall, one of the main hindering factor reported was the high price of a test kit, as probably will not be a surprise to most of you, and small market and unclear regulation blocking access. So the co-lead project will now investigate factors hindering or facilitating uptake at country level in 8 countries. And these will be presented at a community workshop in December and summarized in a policy and practice brief to be available in December. And I would like to acknowledge, well, first Sarah North, because she couldn't be here, but also all the community representatives who responded to the survey, the EHG Diagnostic Task Group, the co-lead researchers, the community key informants, and FIND for supporting the co-lead capacity building and advocacy projects. Thank you. Sorry for taking longer.
Thank you very much, Anise. And now let me introduce our next speaker, Soniel Shilton. Soniel is a public health specialist focusing on operational research for evidence-informed policy change at national, regional, and global level. She joined FIND, the Global Alliance for Diagnostics, in 2017. As hepatitis lead, Soniel is responsible for planning, organizing, and implementing the viral hepatitis portfolio from upstream R&D of emerging technologies to piloting and scale-up of innovative new diagnostics. Soniel started her career in public health as Director of Operations of a community-based health outreach organization in rural Ghana. She has more than 15 years of experience in leading programs and implementation science studies. Please go ahead, Soniel.
Great, thank you very much. I'm going to put this in presenter mode if it'll cooperate. Oh, yes. Great. Well, thank you for inviting me to speak, and thank you everyone for taking the time to be with us today. So I'm going to briefly cover some challenges and opportunities from real-world implementation of hepatitis C self-testing. So some important points just to start off with, to reinforce the idea that hepatitis C self-testing is not here to replace other testing modalities from which the majority of the population learn their status. It's here as an additional tool that we can use to hopefully increase uptake and equity of hepatitis C testing. Now, when we're talking about hepatitis C self-testing in this context, we're specifically talking about the antibody test. So, and that is why it is not a definitive test, but rather the first step towards learning a status. There are some groups who are doing some really interesting work with sample collection, like dried blood spot at home sample collection, and then it's sent for an RNA test for hepatitis C. That's very interesting things, but that is out of scope from what we're talking about today. Today we are talking about the hepatitis C antibody test. And as Nicholas mentioned, it's research use only. And I think this goes to the interesting point that Anne Isabel highlighted in her presentation. So the people who are reporting the availability of hepatitis C self-test, even though there are none yet on the market. And what we're seeing in Malaysia and some other countries is that people are purchasing those tests online or potentially even through different pharmacies. But what they are is professional use rapid diagnostic tests that people are taking home and doing themselves, and so they consider it a self-test. I think this also speaks to the important part that Anne Isabel highlighted about the definition. What self-testing means to various people, it can change. So as Nicholas well highlighted, there has already been a lot of evidence to understand the feasibility and acceptability, the usability, some cost-effectiveness modeling. And now what we want to do is look at hepatitis C self-testing in the real world. So what is really the impact on uptake and linkage and cost? Because a lot of the data that was used for the WHO recommendation was the indirect evidence from HIV self-testing, which is a great, strong portfolio of evidence. But the majority of those studies are done in places like Sub-Saharan Africa. So they, there are some studies in Europe and Central Asia, in the Asian region and the South Americas, but not as much. And it's a different disease. So I won't cover the Pakistan study today, but just to briefly mention, we're looking at secondary distribution of hepatitis C self-testing in the context of an existing door-to-door microelimination campaign. We're very fortunate to be partnering with Aga Khan University for that one. And then in Georgia, as Nicholas has briefly mentioned, and I think Anton's is going to speak on a little bit more, we are integrating hepatitis C self-testing into an existing online HIV self-testing platform, which is funded by Global Fund, and is targeting people who inject drugs and men who have sex with men in Tbilisi and Batumi, two of the main largest cities in the country of Georgia. The primary uptake is to understand if there's an increase in testing uptake among the hepatitis C self-testing arms. It's a 5-arm randomized controlled design, and we estimate to enroll 1,200 participants using the oral fluid test. Now, what I'm going to speak about today is the Malaysia study, because this is ongoing. And now we're speaking about Malaysia because, while Malaysia is in the Western Pacific region, there are a lot of similarities. It is a middle-income country. It has a robust health system. So there are many similarities between the Malaysian context and some within Europe and Central Asia that may allow for some parallels to be drawn. So in the Malaysia study, similar to the Georgia study, we are integrating hepatitis C self-testing onto an existing HIV self-testing platform, but this one targets all key populations nationwide. The primary objective is to understand if hepatitis C self-testing increases testing uptake, and we also want to measure as secondary objectives linkage to care and cost. It's a randomized controlled trial. We estimate to enroll 750 participants, and in this one we are using both the blood-based hepatitis C self-test and the oral fluid-based hepatitis C self-test. And here you can see the clinical trials if you want to look a little bit more about the details of these studies. So for Malaysia, we are fortunate to be working with the Ministry of Health. They're our PI. Our implementation partner is Malaysia AIDS Council. Love Foundation is the Web Development and Data Protection. And then our in-country supportive partner is DNDi. Now, Malaysia is an upper middle income country with a prevalence of 1.9% for hepatitis C. And as I said, we are leveraging on this existing HIV self-test. It's called JAM test, and that pilot study for HIV self-testing is being run by University of Malaya and MAC. So here's the recruitment progress. I'll come back to this slide. We started out quite slow, and then we built up a little bit of steam. So currently, I'll be speaking about the results of the blood-based self-test compared to the control, the standard of care. Now, in the intervention arm, participants signed up on an online platform and they got mailed the test to them. And then they have 2 surveys where they respond to the survey. They ask if they did the test, the results, their perceptions about the test. In the control group, you go online, you sign up, and you're randomized to the control group. You're provided information about the importance of hepatitis C testing, and then you are directed to a local clinic, a primary healthcare clinic, for the hepatitis C test. And you are invited 2 surveys to respond back if you've done the test, the results, and your perceptions on the testing process. So now what we see is after the first and second follow-up survey, of the 96 enrolled in the intervention, so those are getting the blood-based self-test, and the 28 enrolled in the control, 99% of the participants in the intervention arm, so in the self-test arm, completed testing, whereas 25% of the participants in the control arm completed testing. Now, these are preliminary data, so we'll see what this looks like once we enroll more. We are intending to enroll 750 overall, but right now, the preliminary data are showing that there is a certain increase in testing uptake among the participants in the self-testing arm. Now, to mention here the results. So for the intervention, the majority reported back that the self-test was negative, 3% reported it was invalid, and 1% did not want to disclose the results. Now, the invalid rate of 3% is within the range of normal. We normally expect to see a 1 to 2% invalid rate. So 3% is nothing red flaggy yet, but we will continue to watch that. And then in the standard of care, 71% reported back the result as negative, 29 have not received the results yet. This is because in Malaysia, in the primary healthcare clinics, some clinics use rapid diagnostic tests for the antibody, and some use ELISA. So for those clinics where they use the ELISA test, they have to send it away, and it takes some time to get the result back. So this is why participants do not know the results. So some quick lessons learned. The most important thing is the strong collaboration. So previously, the FIND had a chance to work with the Ministry of Health on a hepatitis C project just to introduce the rapid diagnostic test into the primary healthcare centers for hepatitis C. And through working with Ministry of Health and DNDi, we were actually able to bring together the first meeting of Ministry of Health and civil society to talk about hepatitis C. They had many touch points on other diseases, but they had not spoken about hepatitis C. So being able to bring the two groups together helps to start a relationship and conversations that has been really beneficial. And now ministry and community groups are really working together strongly to try and further the decentralization of hepatitis care, because that's what community is telling ministry they would like to see, and the best way to reach them with care. Another important thing is the awareness generation. So we look at this map here. Now, when we were enrolling, we were basing our enrollment numbers off of the enrollment for the HIV self-testing study. And they enrolled over 1,000 participants in less than 2 months. We knew that hepatitis C was not going to be as interesting, or as, people would not have as much awareness on hepatitis C as they had about HIV. So we reduced that, and we said, okay, maybe about 25% we'll get. So we were hoping to see 250 people enrolled in a month. Now, clearly, this has been even less than that. So I think this highlights something that we continually talk about, which is that the awareness for hepatitis C, the demand generation, and the education is really a critical foundational part. And we all need to support those organizations and groups that are doing that, because without that increased awareness, the rest, everything is built on that, right? So we really need to support those groups who are doing that. And then lastly, just quickly on the cost and cost effectiveness. So as Nicholas said, we did a cost effectiveness modeling study as part of the evidence generation for the WHO guidelines. And we looked at 4 case studies. Now, this was all kind of theoretical because we didn't have real world data at the time. And what we found was that hepatitis C self-testing increased the number of people tested and diagnosed and cured, but at a higher cost. And that incremental cost was really driven by differences in prevalence in each setting. So in Vietnam and Georgia, the incremental cost was not so much, about $100 to $150. However, it was $2,600 in China. And this is because the prevalence in China was very, very low. And the prevalence in Vietnam and Georgia ranged from 40 to 60%, whereas in China, it was less than 1%. So this just harkens back to what I showed about the percentage of people, or the number of people who are reporting positive results, which currently is 0. So we need to think about, in this landscape where we have quite small budgets for hepatitis C, what are the best ways to maximize the use of a new technology like this? It's interesting, and it increases equity and it increases uptake of testing, it looks like, which is great. But we really need to think about how to do it in targeted manners where it will be the most cost-effective approach that we can have it be. So thank you very much. I'm keen to answer any questions or hear any feedback later on at the end of the session.
Thank you very much, Sonjel. And for our final speaker, we have Dr. Anton Zwasilevskis. He's a physician trained in infectious disease epidemiology with a background in family medicine. Since 2015, he's worked at the WHO Regional Office for Europe in Copenhagen, Denmark, as a regional expert in hepatitis, HIV prevention, and key populations. In 2016, he coordinated the development of a regional action plan, the guiding document towards the elimination of viral hepatitis in Europe. He also served as a member of the technical advisory group for the Georgia Hepatitis C elimination program and participated in the development of WHO guidelines on viral hepatitis surveillance, testing, and treatment. Please go ahead, Anton.
Thank you very much, Cecilia, for the introduction, and thanks also for organizing this webinar. Thanks, Sonjel, for presenting this interesting study from Malaysia, from Western Pacific. But now I would like to maybe summarize and kind of prepare an introduction for the discussion, for a Q&A session, to look a little bit on the European context, and I mean, to share maybe some of my thoughts or why hepatitis C self-testing would be important for the region and what we need to do to benefit from it. And also I will tell a little bit about some of the projects we are planning or conducting already in Georgia, some of the implementation studies and demonstration studies. So as you know that in Europe, we estimated, the latest estimate, that there are 12 million people living with chronic hepatitis C. And as also presented by Niklas, only 1/4 or 24% to be precise of those people living with hepatitis C are diagnosed. But we also have to remember that our region is very diverse. So we have countries with very low prevalence of hepatitis C in general population, and where the hepatitis C epidemic is concentrated in key populations. And also these are countries in Western Europe, and also in those countries, many countries have reached quite a high level of diagnosis, of testing. But we also have countries in eastern part of the region where we have a quite high prevalence among the general population, and also those countries where most of the undiagnosed fraction is still to be. So it's important to remember that we have different countries and different epidemics, and also we will need different approaches. So about hepatitis C testing, self-testing, as we say. So it was very interesting to see the presentation from EATG, from Anne-Lise, and I hope we can discuss in the Q&A session regarding the whether it will be possible to distinguish between availability and use of hepatitis C self-testing and HIV self-testing, because as we know, and as already mentioned, that currently there are no really officially approved hepatitis C self-tests or self-test kits. Yeah, there are some rapid diagnostic kits, blood tests, or a quick oral fluid hepatitis C self-test that can be bought in the pharmacies in some countries and used at home. But this is not officially really hepatitis C self-test kits. And also reflecting about the WHO recommendation, I must say this is one of the rare cases when WHO has come with the official recommendation before it actually can be implemented. So we were quite, that usually because of the bureaucracy and the guideline development procedures, we usually are a bit late with our recommendation. But in this case, I would say that WHO has been quite timely with its recommendation. It's also why we are conducting several implementation studies, specifically in Georgia. So to say a few words about these studies, one, it was briefly mentioned by Soniel, and is a part of this a global package of studies. So there will be implementation study among implementation study among key populations. So there will be 5 arms, and it will be a randomized control study. So there will be 5 arms, 2 arms or 3 arms among MSM, 1 arm for PWIDs, and there'll be also a control arm. And we will look at the intervention group. There will be 2 different models of delivery. One, it will be courier delivery, so the self-tests will be purchased on the already existing HIV self-testing website, and they will be delivered by a mailing company, by Glovo company, let's say, and the people will receive the package without any, I mean, there will be, of course, instruction inside, but it will be delivered by the courier company. The other mode of delivery will involve peer delivery. So the patients or the participants will receive the self-test kits, and this will be delivered by peers who will also answer some question in case there's some question about how to do the self-test, and so on and so on. And the control group will include participants which will receive instructions where they can go for routine or standard of care HCV testing. So we really will see how HCV self-testing will improve the rate of diagnosis, the linkage to care, and also linkage to treatment. So this will be one of the studies. And finally, we are also planning, we are in the final stage of developing the protocol, implementation study for HCV self-testing among general population in Georgia. As you know, Georgia has also rather high prevalence in the general population, and together with National Center for Disease Control, with the US CDC, and of course with FIND, we are planning quite a large-scale implementation study, which also will test two modes of self-test delivery. When there will be a direct recruitment in the pharmacies and indirect recruitment by female partners of the target population. And we are targeting men, middle-aged men, or let's say men between 30 and 60 years, which have the highest burden in the general population in Georgia. So, and these are the group of the population which have the highest burden, but they have the lowest coverage with linkage to care when diagnosis. So this is like the difficult to reach population in Georgia for some reason. So we also will try to understand why it is that this is the most difficult to reach population. So general population men are between 30 and 60 years. So yeah, basically this will be something new, and we really hope to see better case finding and a better linkage to care using this approach in HCV self-testing. I think that's in brief all what I wanted to say, and I'm sure there are many questions, and I will not take any more time.
Thank you very much, Anton, for showing us the example from Georgia. Yeah, we now have around 10 minutes left for questions for any of the speakers, or if any of the speakers would like to ask each other any questions. I don't see any questions yet in the chat, but please remember that you can either raise your hand in Zoom if you want to talk in person, or just write your question in the chat function.
I think the question we already had from the beginning is about the survey that ETW has conducted, whether it will be possible to differentiate the availability of HCV and HIV self-testing.
Yes, because we had a question about, one was question for HCV and one was for HIV, so it's possible. I mean, because I just had a look at the data. I mean, it's not, I couldn't include everything there, but it's reported available in, for instance, Italy, Spain, Austria, Ukraine, Belarus. But as I said, you know, as was noted, in some countries it's not available. So the self-test. So we have to look, we'll have to look into the interviews about what people did actually report as self-test. But we can get back to you with more precise numbers afterwards.
Any other questions?
Well, just to, I don't want to put Antons on the spot, but I was just wondering from your work, Antons, in the region, especially Eastern Europe and Central Asia. I mean, Georgia is always the example because they have maybe the most ambitious elimination program around there. But from the top of your head, or just like in a reaction, is there any other country that would come to your mind where you would think that could be useful in the future, which have a reasonably developed program, maybe interested in self-care in general, or have good HIV self-testing, or anything along those lines, just from your long-standing work in the region?
Thanks, Niklas. Actually, I was really also curious to hear the views of the participants of this webinar to this question. But if you ask me, that first I have to confess that maybe 5 years ago I was quite skeptical of the HCV self-testing at all, because I mean the certain limitations. Because first of all, it's the test where it's comparing with HIV self-test. Yeah, you will always require confirmation, because you can have also antibodies even in case you have had hepatitis C somewhere in the past and then cured or treated. So it's something, it requires really some understanding from users, but even also from the pharmacists who will test or who will sell this test, for example, if it will be sold in the pharmacy. So it's not as easy. Also because there could be specific groups which might be interested in hepatitis C self-testing. Yeah, we know that also looking also at the HIV experience with HIV self-testing, these are specific risk group which are very aware of the ongoing risk, and they prefer to perform HCV self-testing HIV self-testing regularly. So probably it could be the same case with hepatitis C self-testing. If they are, I don't know, MSM who engage in risk practices, or people who use drugs who are not infected yet, that could be interested in engaging with HCV self-testing. But about the other countries, we know that in Ukraine there might be interest for hepatitis C self-testing. And I don't know, see if we have anybody from Ukraine to comment, but we know that in Ukraine we have, Jana is here, but we know that in Ukraine there is a expanding hepatitis C program. There is also decentralization of hepatitis C treatment that occurred during the pandemic years, and people, and at the same time there might be some barriers to accessing hepatitis C screening through routine testing services. So definitely Ukraine could be one of the countries which would benefit from hepatitis C self-testing. But then we also need the evidence. We need the models which we are developing now in Georgia to be able to promote it further, and to raise the awareness about HCV self-testing. So I think it's really a really rapidly developing area, and for many questions we still don't have answers, I would say.
We have a question, I think it is for Niklas. It says, how can you explain the gap between the people diagnosed and treated in all the region?
Well, I guess, unfortunately, we see in general in all hepatitis C programs, even in the most ambitious ones, quite a big drop off in the cascade. You know, actually, even the really very structured programs, such in Georgia, see quite a big drop off between the serological testing, so the presence of antibodies. And as Anton just has said and insisted on, then you need to do a confirmatory test, because the serology shows only, you know, if you have been exposed to the virus in the past, but only chronic infection is only present when you have continuous viremia, and some people resolve the infection spontaneously. And so that's done through RNA or a NET or through core antigen. So this is an additional diagnostic step, and between those two a lot of people drop off, and then there's a further drop off, as in all care cascades, but quite strong in many hepatitis C programs, between once people know that they have chronic infection and the initiation of treatment. I think one overarching reason for these drop-offs, there are many, and actually would be nice if Sanjay wants to comment as well on that from a very diagnostics perspective. But I think one overarching reason that in many cases is a silent disease. It means you might not have any clinical signs. right? Or very often you don't have clinical signs unless you have advanced liver disease or extrahepatic symptoms, but often it's a silent disease. So people might have a chronic disease for which they have no clinical symptoms, and that might be one of the reasons why you see these drop-offs. Don't know if you want to add 1 or 2 points, Sanjel, from your studies, point of care tests and so forth, might be nice.
Yeah, thank you, Anton's. I'm sorry, thank you, Nicholas. I was reading the chat from Anton's, getting people confused. Yes, so I think that there are a lot of things that we could do from a diagnostic perspective to make it easier for people, and we're not doing that yet. And so, as you mentioned, Nicholas, because there are not clinical symptoms and signs, you know, if it is a complicated process that a recipient of care has to navigate to go from one place to another to get their treatment, they may be less motivated to do so if they are not, you know, feeling the effects of the illness at that time. So I think a large amount of drop off we see is because we're not using clinical reflex testing, right? So not taking a blood sample for somebody if they do an RDT and it's positive, but rather making them go to another place and get the blood draw for the confirmation of viremia and et cetera. So I think when we see those complications and difficulties for the recipient of care, you have a tendency to lose them because there may not be as much motivation for care seeking. And I think it comes back to the earlier point that I said, which is the awareness about hepatitis C is just at a very different level than other conditions. So people may not fully understand the need for treatment.
Thank you very much. I think we are running out of time, unfortunately, but thank you, all of you, very much for attending this webinar and for our speakers for giving us this insight, as Anton's saying, in a very timely way, in the sense that the product is not really yet on the market, but hopefully we'll be able to follow up with another webinar, let's say, hopefully in a year's time when all the HCV self-testing kits are available in the market and we can follow up on experiences. I just wanted to remind you that the recording of this webinar will be available on our webpage. You'll be able to see the link here where you can find it, and you can also follow us on Facebook or Twitter. And of course, we encourage everybody to sign up to European Testing Week if you're interested in participating. And finally, we have the European Test Finder, which is a website where people can search for the nearest testing site for HIV or hepatitis, which is, the site is currently under development and is only launched to the public when we have a sufficient number of testing sites included from each country, but we would like to spread the word and ask you to do the same about the Test Finder, to ask testing sites to sign up. So thanks a lot for attending this webinar, and we hope you enjoyed it and that you found it useful. Have a very nice afternoon.